I'm Sarah Sowden. I work at Newcastle University. I like to start with a piece of research that we published in 2022, all about, it's called actually Levelling Up Health, a practical evidence-based framework for reducing health inequalities. The aim of this piece of work was to present a practical evidence-based framework of guiding principles that help to level up health. So let me just take one example of a targeted disadvantaged communities approach that we're taking here in the northeast of England. So I'd like to introduce you to the Deep End General Practice Networks. And it was about bringing together GPs, which is general practitioners, serving the most deprived communities, to share learning and ideas and to address what is known as the inverse care law. The idea of deep end came from the concept of a swimming pool. So we established in 2020, and our model is very much a partnership model between family practices, public health consultants working in local government and local organisations, for example, the Office for Health Improvement and Disparities. We have a big research component to what we do. So I lead a research element to our deep end work through the auspices of our applied research collaboration, which Newcastle is a part of, but it includes all of the regional universities in the northeast of England. NHS England, which is one of our organisations that works on a regional footprint and a national footprint. And also we have more locally in the northeast and North Cumbria something called the NHS Integrated Care System. It is the ICS, the Integrated Care System, that provides the financing for the interventions that go on in the deep end. And then for the research, we get research funding in to evaluate and co-design those interventions. And so the aim of the network is to bring together these family practices serving the most deprived communities to share learning and ideas, work collaboratively to change the way primary care is delivered and create positive change for patients, practices and communities. One of the approaches we took, given the guiding principles that we know around what works to address inequalities, is that we went out to listen. So we had a view that we wanted to create a deep end network in our area, similar to what they've done in Scotland. We thought it would be useful. But what came out loud and clear from our work was the volume of complex patient need that presented in the deep end. Mental health issues were a huge issue and were often very interlinked with physical health and presentations. So there was really an intermeshing of very complex need, and mental health was always there as part of that. The recruitment and retention challenges that we'd heard about from theory and practice, theory in the inverse care law, were very much borne out in practice. People felt that they were very much struggling to recruit people to work in these areas and also retain staff once they had recruited them. And there was a wider feeling that the healthcare system at large, so that wider, as Paul was saying, the wider, more upstream, midstream area, really failed to recognise the challenges. So I'm going to move on from deep end now and talk to you about the Unfair programme. So Unfair research programme is all about how, addressing the research question, how can we reduce socioeconomic inequalities and avoidable hospital admissions? Unfair has four elements to it. So there is an evidence review, case study work. So we've done some really deep dives into some local areas looking at what are they doing to address health inequalities on the ground. We have a really active public and patient involvement section. What do the public think and feel about health inequalities, and what do they say needs to change to address them? And finally, we did some quantitative data analysis looking at things that have happened in our local context, for example, cuts to funding of local authorities and so on and so forth. So the key messages was that research studies infrequently evaluate equity impacts. So really a lot of the intervention research was not asking the question about what was the impact of this on equity. And that's a really important point, because unless people start shining a spotlight, we'll not know the answers to what works. What we did find, however, is that evidence of interventions that not only reduced inequalities, but unfortunately also those that maintained and exacerbated inequalities. So the take home from that really is that well-meaning interventions do have the potential to do more harm than good. So it's really important to have an equity lens to your inquiry and co-design and evaluation as you go forward. We found effective interventions, however, across all domains of activity, which really underscores the fact that that whole system's action, not, for example, healthcare interventions alone, are required to address inequalities in healthcare outcomes, which again comes back to the importance of systems working. Finally, in terms of what were the characteristics of effective interventions, a lot of those were the ones that were upstream, so didn't require a lot of self-agency on the part of an individual to enact behaviour change. However, those interventions that were were more at an individualised level, the key there really was about being person-centred and supportive in design, which comes back to those guiding principles from Equalise around the principles that really support to enable interventions to try and aim to be more equitable. So I guess the key take home there is that patients and the public must be at the centre of everything we do. Thank you once again.